Good afternoon, everybody. Thank you so much for joining us for today's webinar, which is being held in partnership with CAMFEB, the Kenya Association for Breastfeeding, and Avenue Hospital. I'd like to welcome my panelists, and I'd like to welcome everyone else who's been able to join us. Thank you so much. This webinar is a continuation of what was held last Saturday, because we got so many questions from mothers and caregivers and fathers out there who wanted to know how to maximize their breastfeeding experience. And unfortunately, we weren't able to answer as many questions last time. So we organized this webinar in order to be able to address the frequently asked questions, but also to be able to discuss the importance of mothers and caregivers having access to skilled breastfeeding counseling. And all this is part of this year's World Breastfeeding Week theme, which is supporting breastfeeding for a healthier planet. Now, I'm sure many people would wonder, how does breastfeeding help to combat climate change? And this answer lies in the environmental cost of breastfeeding substitutes in terms of the greenhouse gases, emissions, energy, and water waste. So a fun fact, according to recent studies, manufacturing 1 kg of infant formula powder produces an equivalent of 11 to 14 kgs of carbon dioxide equivalent in greenhouse gases, and 4,700 liters of water. This is just producing 1 kg of infant formula, whereas breastfeeding itself produces zero waste, and the carbon footprint it's only linked to the mother's diet. So given this information, when we talk about like infant formula powder and breast milk substitutes, they should be an option when it comes to breastfeeding if breastfeeding is not possible or if donated human breast milk is not available. And unfortunately in Kenya, we don't have human breast milk donation center that is available to the public. But what happens when a mother wants to breastfeed and instead faces challenges that she did not anticipate or wasn't prepared for? In that case, other options should be explored before infant formula powder or any other substitutes are introduced. Unfortunately, the support and information that a mother requires in order to overcome breastfeeding challenges and make informed feeding choices for her infant are not always accessible. And that's what we are here to discuss. The right of a mother to access skilled breastfeeding support services both in and out of a formal hospital setting for as long as she intends to breastfeed. So let me introduce the panel. We have Claire Kamau, we have Dr. Wamboi Wanyoiken, Shiro Shiera, and Sue Abili Mosi. And all these ladies are, they all work in healthcare, but in different fields and in different, have different backgrounds, professional backgrounds, but all related to maternal and infant health. Welcome, ladies. I'd like you to introduce yourselves and to tell us exactly what you do and why you're so passionate about breastfeeding. Shiro, you can kick us off.
Hi, everyone. As you've heard, my name is Shiro Shiera. I work with moms from the time they're pregnant until they have their baby and follow them through until their baby is up to 6 months. What I do is I support them through the uncertainty of pregnancy. I teach childbirth classes. I support them with breastfeeding, with complementary feeding, with trying to get a structure of sleep around, you know, how to settle out with a baby. Because my desire for them is to become conscious parents. As they are parenting their baby, they're doing it because they know what they're doing and how to do it right. I'm super passionate about the journey of pregnancy, birth, breastfeeding, and thereafter. So I have a platform called Nurturing Moms. Nurturing Moms is on Facebook. It's on YouTube, where I have videos that are helping moms with different questions that they may have with regards to what we're talking about now, which is breastfeeding, pregnancy, labor and birth. How do I go through that? I'm currently also the chairperson of the Kenya Association for Breastfeeding, where we are promoting, supporting, and protecting the well-being of children and ensuring that their mothers are able to successfully breastfeed them till 6 months and beyond. So I'm happy to be here and to be in the panel with these other amazing ladies.
Thank you, Cheryl. Good to have you here. Next, we'll have, please tell us some more about yourself and why you're so passionate about breastfeeding.
Good afternoon, everyone. Thank you so much for joining our webinar. My name is Suabi Lumosi. I'm a doula and a breastfeeding counselor. I am so passionate about helping women. I work with women from the time they are pregnant, mostly from 28 weeks. I work with them in preparation for labor and also after delivery. I decided to concentrate on this field mainly because there was so much misinformation out there regarding the ability of a mother not to breastfeed versus breastfeeding. There were just so many myths and there was a lot of discouragement, and I met a lot of mothers who just felt that breastfeeding is a gift. Not everyone can breastfeed. So that was one of the reasons why I really wanted to get certified to be able to offer counseling as a breastfeeding counselor. I have a platform on Facebook and Instagram. I call myself Suabi Nairobi _Nairobi Doula. And I am very excited actually to be part of the panel. And I look forward to just interacting with all of you. Thank you.
Thank you, Suabi. Next, we have Claire. Claire, please tell us a bit about yourself and also your passion.
Okay. Hi, everyone. It's good to be here with all of you. My name is Claire Kamau. I'm a mother of 2 boys, 21 and 11. And I'm the chief nurse of Avenue Parklands. Now, my passion in breastfeeding support came because I did suffer a lot, as much as I'm a nurse and my mom was a nurse. So that tells you it's not obvious that all nurses know how to breastfeed or support others how to breastfeed. And so I created this extra interest, and that's how come I looked for a course that made me a lactation support and educator. And I'm happy to be here. We'll try and answer the questions as accurately as possible, given our few years of experience. Thank you.
Thank you, Claire. Very nice to have you here. Dr. Wambui Wanyoike, karibu sana. Please introduce yourself. Tell us more about yourself, rather.
Thank you, Josie. So my name's Dr. Wambui Wanyoike. I'm a pediatrician. I'm based at MP Shah Children's Hospital here in Nairobi, Parklands. I'm very passionate about breastfeeding. I work with mothers from the time they give birth onto when the children are about 18 to 21 years old. I've seen the effects of breastfeeding in terms of preventing a lot of illnesses, diarrheal illnesses, pneumonia, allergic skin conditions, and asthma as well. And I've seen the effects of poor breastfeeding, especially in neonates where babies don't breastfeed well and come in very early in life for dialysis because of poor kidney functions, because of dehydration, just from lack of breastfeeding or poor breastfeeding techniques. So I'm happy to be in this panel to answer questions. Breastfeeding is a journey that should be enjoyable, and it's not a natural process. It's something that's learned, and we're here to support you, and I'm looking forward to answering all your questions. Thank you, Josie.
Okay, thank you, Dr. I think there might be a bit of a connection issue there, but I think we still got the gist of it. So it's actually very interesting what Claire, being the head nurse at Avenue Parklands, and also what Dr. said with regards to what you see when you're in a medical profession and what you see as the effects of mothers not having sufficient breastfeeding support. So maybe this one I'll direct to you, Claire. What do you think? What would you like to see changed? What do you think would make a better difference for mothers, especially in the hospital setting, when it comes to having access to skilled breastfeeding counseling? And why is there that gap currently?
Okay, thanks, Josie, for the question. For me, what I would want to see differently is the nurses getting more involved in the patient care as part of the journey. Remember, this is a journey, and this is towards the end. And now when the baby is here and at least the journey of carrying the baby is over, then the anxiety starts of how to feed this baby and deal with all the challenges of the emotional changes. And the challenge I find is that not all nurses actually know how to support these mothers. And so they do according to tradition or what they think, or they actually assume it should be instinctive for this mother. And so what I would want to see is for the nurses dealing with these mothers to be more involved. And so for us at Avenue, we try and train these nurses on the ground. For me, I do the rounds with them and talk to these mothers. And so they learn along the way. So the gap mainly is because it's not taught during our training. So it's not part of the curriculum. And so being a part of the chief nurses in Nairobi, we are trying to work with the nursing council to see whether that can be incorporated into the curriculum in the future. But in the meantime, I think we just have to do a lot of awareness for these mothers to know that they can ask and depend on us, and we will try our level best. Thank you, Josie.
Thank you, Claire. On that same point, maybe going to Shiro, as you said, because you work all the way from when you're doing the childbirth preparation classes all the way to complementary feeding. And I'm sure you also perhaps see mothers who you haven't necessarily met before pregnancy, but you meet them now when they're looking specifically for breastfeeding support. Sure, do you see a big difference in mothers who attend your breastfeeding preparation classes and the ones who now just come in because they need ad hoc help? And what kind of gap are you experiencing? Is it a confidence gap, an information gap? What do you see when you're supporting moms postpartum?
Thank you, Josie. There's definitely a really huge gap with those moms who either attended a childbirth class or have even done a prenatal class on breastfeeding. There is a lot of confidence in those mothers. Those who haven't, even as much as that they are going to hospital to deliver and have been seeing their doctor throughout their prenatal visits, they have no confidence with breastfeeding. And they tell me that when they gave birth, the nurse gave them the baby and said, here, shika, nyonyesha mtoto. So you ask how, they say, wekelea mtoto kwa matiti atanyonya. There's the myth that it's going to be natural. But it doesn't happen naturally for all mothers. For some, it works perfectly. Whether you did a class or not, it works. But for majority, unfortunately, have no idea what to do. And I also find the nurses in hospitals tend to give the advice that they used when they were nursing maybe their babies. Things like, oh, you have to hold your breast a certain way. And here I am saying, let's try and avoid holding the breast like that. And the mom says, no, the nurse told me I have to hold my breast that way because that's the way you're supposed to hold a baby. But the nurses I find are also not doing the continuous professional development. What's the current research talking about? What is it saying about breastfeeding? How should a mother be positioned? How should she attach the baby? They're still forcing a mother to do the cradle hold. Even for those that I've taught and said, you know, for a newborn, it's always best to do the cross cradle. And that way you're able to get a faster, easier latch I'll come and visit the mom, and she says, you know what? The nurse completely threw what you had told me out of the window and said, I must hold the baby this way. I find we shouldn't force the moms to hold the baby a certain way. Usually what I say, as long as that mother is comfortable, and it's weird for you and you've never seen a mother holding the baby in the football hold, this is the first time you're seeing that and you think, oh my gosh, why would you be doing that? As long as the mom is comfortable and the baby is also comfortable, let's not try and just break their confidence, and where they start to second guess themselves and think, oh my gosh, I'm not doing the right thing the right way. So I go by what Claire has said, the hospital staff, there is where the first point of contact a mother has with her baby and the healthcare staff. That's the first line of contact. If Josie, myself, and other lactation specialists who are here on the call were not there, then the moms would struggle so much. So my desire is for these nurses to also get that right training. Then we are not having a confusion of this nurse said this, your doula said this, another nurse came and threw that out the window and said something else.
Yeah, thanks for that, Shiro, because it's actually very interesting. You've touched on quite some interesting points. This week, there was a webinar that was jointly hosted by the Global Breastfeeding Collective, WHO, and UNICEF.
Yes.
And Dr. Lawrence Grumer-Strawn of WHO stated that for skilled breastfeeding counseling to be effective, health workers must provide mothers and families with education, reassurance and confidence, practical help, problem solving, anticipatory guidance, and consistent information. And he really focused on the idea of consistent information, because ideally, whichever health worker you go to, whether it's the maternity nurse, whether it's the postnatal care nurse, comes to breastfeeding, the information should be consistent. The support should also be consistent. And now that you've touched on that conflict, where you have a conflict between what the doulas and lactation specialists are saying, what the nurse is saying, and what the doctor is saying, I'll direct this one to Daktari. Dr. Wambui, do you ever experience points where you tell a mother this is what you're supposed to be doing ideally in order to have effective breastfeeding experience and journey, but then they come back to you and they tell you, oh no, this is not what I was told, and this is not going the way it was supposed to be? Do you tend to experience those conflicts, whether it's within your field, as even between you as pediatricians, whether it's with the nurses? What's been your experience with that?
In terms of conflicting information, most times it comes from the community. So the community will be the one giving this mother's feedback on how they're supposed to breastfeed, when they're supposed to breastfeed, what they're supposed to add either in their diet or the baby's diet. So you have mother saying, my baby's hiccuping, I was told by so and so, my baby water, or the baby's not getting food full, so add a substitute to milk, either through formula or start feeding very early. So those are the challenges we mainly get. So you have mothers not exclusively breastfeeding because they're supplementing with something else. And remember, demand and supply. So if you're supplementing with something else, you're definitely not going to get enough milk. So mainly in terms of duration of breastfeeding, that's the conflict we usually get in adding. For latching, positioning, usually not much of a challenge. So mainly just addition of substitutes early on in breastfeeding, making it a bit difficult for mothers to breastfeed.
Okay. Okay, thanks, Dr. Your connection was a bit unstable, but from what I gathered, for you, the biggest issue is community advice rather than people getting advice from skilled health workers. And again, this is what we're talking about. So it's actually good that you mentioned that I think because of lack of access to skilled breastfeeding counselors, so mothers then tend to rely on their relatives and the rest of the community. So this one is to Sue Abby. Sue Abby, what has been your experience with the mothers that you have seen? Who do they seem to turn to maybe before they come to you, or how do you end up getting your clients? Is it usually word of mouth, or do people out there know that you are a skilled, certified breastfeeding counselor?
Thanks, Josie. Most of my clients are actually through referral. So funny enough, by the time I get a mom who is in need of help, it's usually after they have gone through a ton of, first of all, Google, Dr. Google. Then they've gone through, I find many of them also go through a lot of Facebook pages where they have a whole lot of opinion, which just overwhelms them. So by the time they come to me, they have tried all these other avenues apart from the hospital, because now I also find that we have a tug of war between some pediatricians and also what we as the lactation counselors say. So most of my clients have been through referrals who I have actually helped, maybe their friend or neighbor, and they actually give my number to someone else. Very few have come in through my online platform. I think because there's not, I don't find that there's a great sensitization out there regarding the need and actually the availability of support that is there. People tend to ask for help after they hit a roadblock. And usually sometimes it's a bit, sometimes a mom can come to you when you're just saying, oh my gosh, I wish you knew this before. You shouldn't even have had to walk through this journey. Or like even being told myths such as breastfeeding should be painful for the first month, it's normal, no one should tell you otherwise. And we're like, no, it should not be painful. It can be uncomfortable at the beginning, but it should not be painful. So I find that there's also a need to, I think the nation, maybe Kenya, needs to have a lot of sensitization that there need to be support. There is support. Of course, consistency has to start from the healthcare providers, because it's very hard to be in a tug of war between the nurse and the pediatrician. And here you are as a lactation counselor. And by the time they go for their 2 weeks or 6 weeks check, it's almost as though they are trying to believe you before you get their buy-in, especially if it's a recurring problem. Sometimes when they go back to hospital for a visit, it's as though you go back in the cycle to reassure them that the information you're actually relaying to them is actually evidence-based information, and it's not a matter of a nurse who was there 20 years ago told someone else who told someone else, and that's how they're training, based on who was inducting them when they were becoming a nurse or in their field. So I feel that for me, sensitization is key. Like there just needs to be sensitization that there's help, and it does not have to be painful, and you are not a failure. It is actually a learning process. It is not a natural occurrence for many.
Yeah, thank you, Suabi. I think that is a very, very powerful statement. You're not a failure if you struggle with breastfeeding. The fault is not on you. We just need to invest more in skilled support, which is very, very important. I know also what you've touched on is very important about having multidisciplinary teams where you're all working together, where you're working with the gynecologist from the beginning, and then you move on, because ideally the gynecologist is the one who should be able, or the obstetrician is the one who should be able to refer a mother to a lactation specialist, a lactation educator for classes, breastfeeding preparation classes, not even childbirth, because there's an entire separate class just for breastfeeding for pregnant women. And then after that, now you walk the journey with whether it's the midwife and also, or whether it's a pediatrician, but there's always somebody who the mother can refer to. So do we think that this can be the future, that you can actually find yourselves in a team where you have 3-4 people, healthcare workers supporting a mother? Daktari, do you think that's possible, where one day we'll be able to work as lactation specialists and you'll be able to refer your patients to us, and it will be teamwork rather than the push and pull that Sue has talked about?
Yes, I think we should find ways to be able to meet these mothers early when they're still expectant. As you said, there's a team with the OBGYN, the lactation specialist, and nurse, the pediatrician. I think we should all be on board from the get-go and walk that journey with the mother, because it's also about nutrition during pregnancy, to be able to have enough stores to be able to breastfeed. So this is a journey I think we should have as a team. When we're doing the birthing plan, we should all be there and present with the mother. Hopefully, if we can set up institutions or places where as a mother comes in for her review on the way forward and how we walk this journey with her.
Thank you, Daktari. To you, Claire, especially being the head nurse, do you think it would be helpful to have not necessarily a separate department, but a dedicated person who is just like the way you find right now in Kenya? We don't have a Kenyan lactation consultant, but when you look out there, you tend to find that hospitals have lactation consultants who work specifically in that hospital, and that's all they do. Claire, do you think that is feasible? Do you think that's possible, in addition to what you were saying about introducing lactation and breastfeeding support to the nursing curriculum, but just having specific people just working in lactation in the wards?
Yes, thanks, Josie. That is quite an interesting concept, and yes, it would really help to have this one person who actually works with the mothers, say like the way you'd have a nutritionist who is doing the rounds for all the patients in the hospital. If we had this one specialized on lactation who actually works with the mothers and does daily sessions with them, I think that that is a feasible idea. The only challenge is, I think we've not done enough sensitization to the public that they can know, because of course for me as a chief nurse, there's also the admin part. Is this making some sense when I have to account for numbers as to why I should have this clinic? You get. So if we've not sensitized and also marketed ourselves that we have these services, then of course the public will not know and they will not reach out to us. But if the numbers are good enough, yes, that is a worthy cost to invest in for all hospitals, such that then we have a healthy community, and that will also help us progressively to also work on the non-communicable diseases. But now it's a lot of trial and error right now. The management still hasn't felt our part per se. That's what I would say. So it becomes difficult to convince them that you need a department to do this. So I think we need more awareness, and yes, it's a feasible idea.
Okay, thank you for that, Claire. Yes, and I think that's where now, even when with the Global Breastfeeding Collective, WHO and UNICEF is urging governments to take the access to skilled breastfeeding counselors more seriously, because we need a lot more policymakers, people in government, donors, spending more money in this area where programs are put in place, where awareness and advocacy happens. Because like as Claire, and it's a very valid point, there's no point of having a breastfeeding and lactation specific center if women out there don't think that that support is very important. So I think we definitely need to keep on lobbying the government for that, because some of these things have to be top down, because then also they have more access to information dissemination than, for instance, the rest of us do. Thank you so much, ladies. I think that's been a wonderful discussion. I'd like now to dive into the frequently asked questions that we got from a number of mothers from last Saturday and the ones that we are getting now. And I think it will all still tie into this, again, access to skilled counseling, because of course we are all answering these questions from a place of knowledge and experience and evidence-based answers. So I think this is also going to be a very good demonstration of why mothers should be able to reach out to people, and why we need to create awareness about the support that's available. So let me begin with what is most prevalent at the moment, which is the COVID-19. And despite a lot of information and infographics from WHO that mothers should continue breastfeeding even if they are suspected to be COVID-19 positive, or if they have a confirmed case of COVID-19, if they are a confirmed case, we are still seeing, again, I think because of lack of information, mothers who are not breastfeeding. But Shiro, let me start with you. What are you telling your mothers? What are you telling the mothers who come to you with regards to COVID-19 and how to handle the situation with their babies?
Well, thanks, Josie. What I'm telling them is to just continue to breastfeed and to use the measures that have been set out for them in terms of proper hygiene, wearing a mask, washing your hands with soap and running water. If this mother feels that she's COVID positive, because I had two moms who had a flu, and they first panic and say, I'm not going to breastfeed until I get my COVID-19 results back. And I try to tell them and reassure them, look, you can still breastfeed. Just put on your mask as you're breastfeeding your baby. Ensure you're washing your hands, sterilizing them. Just use the appropriate measures to stay clean and to stay safe and avoid, sneezing or coughing over your baby. However, Josie, I found there's still a lot of fear in their community, whereby their family is telling them you cannot continue to breastfeed until we get the COVID results. So for them, the risk outweighs the benefit for breastfeeding. And yet we've been told, and World Health Organization has put out so many infographics, that you still can breastfeed your baby, even if your results come out as being COVID-19 positive, because they've not even found the virus in breast milk. For moms who've been found to be positive, when they test the breast milk, there's no virus in the breast milk. So you can still continue to breastfeed, and actually the benefit of the antibodies that you're passing to your baby is of great benefit to them. If they do get the COVID-19, your body has already started to fight the illness for them. But there's still a lot of fear, even with the counseling of it's okay to continue to breastfeed. I find the moms are still being very fearful, but I think it's because of all the pressure that there is in the community and from their families.
Yeah, thanks, Shiro. Yeah, there is a lot of stigma and there is a lot of conflicting and misleading information out there, unfortunately. So Abby, how have you had to now change the way you support mothers during this COVID period?
This period has been very trying for many mothers. At the beginning of the lockdown, the first concern for most mothers were, of course, I don't want anyone to come near my baby. So what I did was offer a lot of phone support. both day and night, because of course you cannot force your way into a mother's home if she's not comfortable. But the few that I have managed to do home visits, I had to also take the necessary precaution, kept my mask on the whole time. I would do changes of clothes. I would wear something different even though I was in my private car, just also so that they could feel that they are safe. So I would do a change of clothes. I would keep changing my mask. I would do my social distance. And even during demonstration, many times pre-COVID, there was I was able to physically maybe ask, can I be able to support you and show you how to maybe latch your child, maybe like hold her breasts at some point. But this time I had to come up with ways of being very, very using very key words and just ensuring that they do it without me necessarily physically touching them. So I would be in the room with them. Like for one mother of I think I visited 2 months ago. I was in the room with her, but I did not have any physical contact with her. So like I would have to walk her through the whole process. Okay, now do this, don't do this, do this. Are you seeing a difference? And I actually found it took more time compared to pre-COVID, but it actually worked. So yeah, that has been how I had to adjust my my support system, my support, so that they can be able to be comfortable and also have confidence, and as well as protect myself and protect the client when need be, when it's a physical visit. But other than that, we tried video calls, challenging, but actually works, because remember, during support, as you're offering support to women, it's provide information. So as I provide the evidence information and I build their confidence, then they're able to actually apply what I suggest. Then I've been able to see results even by a virtual support system. So it's been an interesting growth curve, but we're getting there. Challenges here and there, but we're getting there in terms of support.
I think that's very encouraging, even for the mothers out there, to know that even during this period when physical distancing is, of course, quite necessary, that you can still access support, and it's still going to be effective support. And then for you, Claire, being in a hospital setting, what has been your policy, especially in the beginning? Was it, because it's also been a very trial and error period, just like Suabi has said, were you guys encouraging mothers to still stay with their babies even if they were suspected, or are you doing the separation? And what's the current policy at the moment?
Okay, thanks, Josie. In the hospital, we have a set team that deals with COVID-19. So we have placed systems in place, and for any COVID-19 mother who comes, there is a COVID ward for every positive patient. So whether you're coming to deliver, coming for surgery, or just an ICU patient, whatever, but you're all clustered together. And so what we do for the mothers is we put them in a room, because what we want to do is to encourage rooming in with the baby so that they can bond. However, we teach them before the baby comes, say they are going for elective surgery or they are going for a normal delivery, you prepare them psychologically, because they're very scared to infect this baby with COVID. So what we do is teach them on the infection control measures, just like have been mentioned, washing your hands, and now you can't keep distance with your baby. So in this case, you've got to use a mask, and not just the usual mask that we wear outside, or the usual hospital blue and white kind of masks. We wear an N95 mask because it's 95% protective to the person that you're sharing the room with. So that's how we protect this baby. But everything else continues. If you need to kangaroo, if you need to breastfeed, clothes, and they bond. You don't necessarily have to put the baby separately in the nursery and all. So yes, for us, we've received, so far, we've done like almost close to 10 cases of COVID patients. And we have a set theater for that, separate from the rest of the patients, because even the kind of cleaning we've got to do after, and you've got to ensure there are no other cases running at the same time. So we've put all those measures to protect even the rest of the public. Yeah, but it's been a lot of, it's not easy, but every day we are getting better. Yeah, so feel confident for those out there. We've got your back, and we will not chase you away because you come to say, I want to deliver, and here I am, I have the COVID test, and they are positive. Now, for those we don't know yet, if you're positive, once you come, it's mandatory for all inpatients to have a test done. So you are a suspect. So even if you're not yet confirmed, you still put separately, but you get the care as usual, only that we will now probably use an extra more personal protective equipment because we are not sure, versus when you're in the COVID ward already confirmed, then it's easier because it's only one person taking care of everybody. So the cost goes down, because that has been another challenge, and insurances don't want to cover and all that. Yeah, it's been quite a dramatic period. Yeah.
Okay, thank you, Claire. And that's very, very encouraging, and it's definitely gives people out there confidence to know that first of all, measures have been put in place, and that you can still have your baby with you. And I think the same actually does apply to home-based. If someone is recovering, so to speak, at home, again, what Claire has said, it's just about taking the preventative measures, but keeping baby close. And just to reiterate also what Shiro had said about the antibodies, that your baby still needs those antibodies, and actually it will help them a lot. There was also a question, so again, in this idea of breastfeeding in crisis, there was also the ongoing discussion around breastfeeding when HIV positive and what the guidelines are. Daktari, I think I'll ask you this one. Because there was a question, is it possible for a mother who has tested positive for HIV to still breastfeed her baby? And I've put it in this same category because, again, with all the stigma and everything, I think some of the guidelines and protocols that were used with HIV were also being used with COVID. So Daktari, how should HIV positive mother go about breastfeeding their child? Is Daktari still on the call? I think we've lost her. I think we've lost her for her. Maybe Shiro, you can take this and you can share it with Claire as well.
Repeat your question, Josie. Sorry, I lost you.
Oh, there you are, Daktari. You're back.
Yes.
Okay.
Repeat your question.
It was regarding HIV because, again, it falls under the same category as breastfeeding in a crisis. And so there was a question about, is it possible for a mother who has tested positive for HIV to still breastfeed her baby?
Okay.
And
yes.
because some of the protocols that were being used for COVID were being copy and pasted from the HIV guidelines, but we know that has also changed. So it's good to hear from you.
Okay, so for the HIV group, the breastfeeding mothers, we try and identify them as soon as possible. Remember, we are now starting antiretroviral therapy as soon as someone is tested positive, pregnant or non-pregnant women, so as to build the immune system. So once a mother is tested positive, we start her on antiretroviral therapy as soon as the first contact. And we still encourage breastfeeding in our setup. This is because it has been shown to prevent a lot of this diarrheal diseases, pneumonia, that these children are at risk for if they have low immunity. So the mother is still encouraged to breastfeed exclusively for 6 months. And the guideline has changed for her. She can actually continue breastfeeding when she starts complementary feeding afterwards. So she's encouraged to breastfeed exclusively for 6 months. And then thereafter, during the introduction of complementary foods, and for as long as she would like. Testing is done for the child once cessation of breastfeeding occurs. So mothers are still encouraged. Remember, the benefit does outweigh the risk. The child is well nourished, gets a good immunity as well, because remember, they may be immunocompromised. So their immunity is really boosted and they're able to live longer, and actually does reduce significantly when the mother is compliant on her medication and continues her follow-up with a good CD4 count and a low viral load. So I encourage mothers to continue breastfeeding despite a HIV positive result.
So would she need to be on ARVs?
Yes, she needs to be on her ARVs. She needs to be compliant and continue follow-up. We do the routine checks of our CD4 counts and our viral load as well to make sure it's undetectable. But even though it is, we still encourage the mother to continue breastfeeding. And the child is also put on some prophylactic treatment as well. And we'll continue following up the pair, the mother and the child, throughout the breastfeeding period to make sure the baby tests negative. And if the baby does test positive, we start the baby on therapy as well. As I say, the risk reduces significantly if the mother is compliant on her medication.
Okay, thank you very much. Thank you so much for that. So moving on to the other questions that we got. So here is one on how do you achieve a deep latch? And I'll join that together with what happens if the baby is not able to latch on properly because the nipple is too big for her tiny mouth. Shiro, would you be able to take us through that one? Can you hear me?
Yes,
Oh,
I can. So the latch is the biggest thing. And if moms are able to get the latch right, then most, if not all, the breastfeeding problems will diminish, because usually if the latch is too shallow, so I'm going to use my model breast. If the baby's latch is too shallow and all they have in their mouth is the nipple, it tends to get really sore, tender, and it can start to crack and to bleed. So what a mom ideally wants to do is to ensure that when the baby is showing interest of wanting to breastfeed by putting hands in the mouth, thrusting their tongue in the mouth, turning their head, before they start to cry, because crying is the last sign of hunger. When mom starts to see the signs that my baby wants to feed, you will take out your breast and you're gonna hold 4 fingers under and your thumb on top, okay, like that. As I said earlier, we're not gonna do this because if you do this, then you're only allowing the baby to take what's in between my fingers, and that's the nipple. 4 fingers under and your thumb on top. If your areola is larger than this breast, then at least an inch of it should be in the baby's mouth. So I want to use the hold that I always use when I'm teaching moms who are having newborns, is to put your hand in between the baby's leg, ensure their back is well supported. This hand goes under you that way, 4 fingers under, and you tickle the baby's nose, top lip, bottom lip, and they'll have a gaping mouth. Once your baby's mouth is gaping, now the trick about the latch is how soon and how fast you see the gaping mouth and how quickly you bring the baby to the breast. So I'll just lower that so you can see. 4 fingers under, thumb on top, this hand goes under me. And once my baby opens wide, I bring baby to the breast. You shouldn't take the breast down to the baby. You're supposed to be seated back comfortably, back supported, and this baby is the one that will come to the breast. Another thing is ensure that your baby is completely facing the breast. Because sometimes we do this, the head is looking at the breast, but the tummy is looking up. So make sure you turn your baby's tummy completely to face you, to face mommy, so that then your chest, their tummy, you're facing each other. And you'll see that by the ear, the shoulder, and your baby's hip must be in a straight line. But unfortunately, when their tummy is looking somewhere else, the ear is there and then everything else is misaligned. So that will always give you the wrong latch, whereby the baby is eating sideways. So remember, tummy, baby is facing their food, and then 4 fingers under, and the trick is how quickly you find baby's mouth is gaping and how quickly you cover the breast with the baby's mouth. And make sure that most of this is in the baby's mouth. So you'll tend to see the bottom part is almost completely covered. If you see a bit of the top part, that's still okay. Okay, it should be quiet, no clicking sounds, no all you're hearing is the baby swallow. So nobody should know, if they get into a room, nobody should hear the baby breastfeeding. It should be really quiet. And breastfeeding shouldn't be painful. If you are having pain throughout the feeding session, then there's something wrong. You've got to stop. So this thing of, no, don't worry, breastfeeding is painful for 2 weeks and then it's fine. No. There's a tenderness or sensitivity you get when you start off as a new mom. There's a sensitivity for a few seconds when the baby just latches. After about 30 seconds, it should go away and you feel completely comfortable. All you experience is the tagging feeling on your breast, but no pain should be there. Yeah.
Thank you, Shiro. That is very, very detailed, very informative. Thank you very, very much. Okay, so this one is for Suabi. So once now you tend to find that mothers have, maybe they've got the latch going and then they've been discharged from hospital and then you get that call of, I don't think I have enough milk. I think that's one thing that for all of us support specialists, that is the number one concern that mothers have. So what's usually your advice when a mother calls you with a 4-day-old baby and she's like, I don't have enough milk?
First of all, I ask her, why do you think you don't have enough milk? So that I'm able to demystify if it's actually a perception thing or it's actual that she doesn't have enough milk. And most of the time, I find that mothers are actually just comparing their experience with other mothers, especially on Facebook groups. But then I go back into asking, how many wet diapers does your child, do you change? Does your child produce in a day? They might say 5, 6, others might say 4, and I would be like, okay, how many times a day do you change your baby? Some would say twice. So then I would inform them, first of all, how to know your child is having enough milk or I'm producing enough for my baby is the number of wet diapers. So I tell them 6 to 8 wet diapers is a good number. That's how we're able to tell that your baby is not dehydrated. Secondly, when you're, because at the beginning of, so for a new mom, her breast usually is very full the first few days. And then with time, as the baby has already established a good latch, then there is usually a process where I see the milk levels up. So many mothers I also find compare their full breasts of maybe the first week of birth to maybe now that they are 5, 6 weeks later, they're like, I think I don't have enough milk because my breast is not getting as big as how it used to get when I was a new mom. So first I would tell them the baby is actually establishing now a pattern. So if you're comparing it from the previous few days, first of all, don't compare it, check the wet diapers, check also the poo, is the baby peeing enough? We'd say the baby is pooing is enough. Also, when it comes to pumping, I also try to demystify in terms of looking at how much they are pumping to say that they don't have enough milk. So I try to encourage them not to look at the amount of milk produced in a pumping session as an indicator of them having little milk or less milk. Secondly, also for the breast, I tell them, how does your breast feel after the baby has finished breastfeeding? Does it feel a bit softer? Does it feel lighter? Then, of course, based on the response, how also to know that a baby has had enough to feed. When the mother begins, the breast is a bit hard. And so as the breastfeeding goes on, because of the letdown and the milk is being produced and released, the breast tends to soften. So then I give an indication of, is your breast feeling a bit lighter after a breastfeeding session? Yes. then that's a good indication that the baby is actually emptying the breast. Also, when it comes to the pooing, I also ask, what color is the poo? Is it mustardy? Is it green? So that I'm able to know, is the baby having enough and going deep enough from the foremilk into the hind milk? Or is the baby just focusing on the foremilk? So based on the answers, then I'm able to give the information and confidence that your breast is soft after a feed, you're okay. You're having wet diapers, you're okay. The baby is okay, you have enough milk. Because and just to try and encourage them not to compare, whether it was with their first child or whether it's with their friends. So the experience is different. The milk and the baby cycle is different for every pregnancy, for every person. Key indication, wet diapers, we need enough wet diapers. And the feeling of the breast, even after breastfeeding, should be a good indication of whether or not they're having enough milk or producing enough, as they say. But most of the time, I find they're actually producing enough milk, but it's just a confidence thing based on myths that they hear or they're told that you have to have this gushing milk every single time you're breastfeeding. So I just try to tell them, yes, your milk is leveling up. At the beginning, it's kidogo, then it becomes a lot, then your baby, now as the baby grows, the milk levels up. So it's okay if your breast is not becoming so large as what you were used to previously. So that really gives them the confidence that they're able to do this. And yeah, that's what I would say. Maybe Shiro, you can add something to that.
You've answered really well, Suabi.
Yeah.
Yeah, there's nothing to add.
Yeah, and actually, Suabi, you've covered quite a number of the questions. They were all, a lot of them were to do with the milk supply and milk exchange. How do I know if my baby is getting enough? Do I still have the chance to exclusively breastfeed even if my baby is 2 months old and a past of experience of low milk supply? And that one you've addressed again by saying like each breastfeeding experience is very different. Again, I'm not sure if my baby is getting enough. So you've pointed out on the indicators of diapers, having at least a minimum of 6 to 8 wet diapers a day, 4 to 5 dirty stool diapers in a day in the first few weeks. So I think that's more or less covered a lot of this. My next question would be to Daktari, because it does happen that sometimes mother's milk is not enough and mother is discharged. And I know you mentioned this where you see mothers coming back with their babies, unfortunately, to be readmitted because of dehydration, hypoglycemia, and those kind of things. So my question is now, once the baby is put back on track, like what support is then offered to make sure that the mother is still now able to produce enough?
Okay, so for the milk production, it's demand and supply. So encouraging the mother to breastfeed every 2 to 3 hours. You have a lot of mothers asking why during the day, they are okay breastfeeding at that duration, every 2 to 3 hours. But at night, sometimes if they do not wake up to actually get the baby up and breastfeed because they feel the baby should sleep well as they were in the hospital. But usually that's because they're in the nursery and they're being fed by the nurses. So when they go home, it's just encouraging them, especially at night, not to forget to wake up their baby to breastfeed every 2 to 3 hours. Monitor their diaper changes, as Suabi had said, and their stool patterns as well. Sometimes mothers may be given some supplements to enhance milk production. Sometimes they may be given some drugs. The popular one that we know is the domperidone motilium. A lot of mothers are given that medication just to boost up their supply for a short period of time until the letdown reflex is better and their milk production is better. And then from then, we can wean them off that medication and continue them with just the exclusive breastfeeding, frequent breastfeeding, and pumping as well, just to increase their milk supply and make sure it's adequate.
Okay, yeah, thank you. So again, that idea of demand equals supply, the more you put on the baby on the breast, the more your body is going to produce. Thank you. Claire, I think for me, it's my question to you is with regards to the supplementation that sometimes happens in hospitals, and then mother and baby go home, and then they find that there's a bit of supply gap because the baby has had quite a bit of formula. So my question would be, what leads to that introduction of supplementing while still in the hospital? And how can, again, a mother be supported when she goes home so that she's able to meet her baby's demands when the baby has already been supplemented?
Okay.
So that's to Claire.
Thanks, Josie. Now, ideally, we shouldn't be supplementing, but sometimes when you're in the hospital, say it's post a CS of a very long delivery, the mother is a bit tired. So sometimes the baby demands that the mother is not ready to latch on. So we do supplement, yes, to avoid hypoglycemia and dehydration, but then that should not become the norm. Sometimes we get a challenge where the mother just keeps, becomes, I don't know whether to call it complacent. They just want, so long as somebody is taking care, she just wants to be left alone to rest. For me and my nurses, we insist it's got to be as soon as mother is given a few hours to rest, she has got to put the baby on the breast, because the faster the baby and the mother bond and the milk letdown begins, the better for all of us. So if the mother gets used to being supplemented for, and the nurses also now take it as a norm, then it becomes very hard when they are going home, because first they've not, the baby and the mother have not gotten used to each other, and it becomes quite stressful for this mother, and it risks even postnatal depression once they go home, because the demand is beating what she can meet. Or on the other excess, she now decides to go the non way. And of course, if you're not stimulating the breast, there'll be no letdown. Yeah, so that's quite a challenge. But for us, we support just if there is need be, just to support the mother. But it shouldn't be a replacement of the breast milk. The second part of the question was what, Josie? Remind me.
Actually, you've covered everything, because it was about now when the mother goes home, if supplementation has already begun in hospital, sometimes there tends to be that gap when they go home, but you've also covered that. Just again, like you said, to make sure that before discharge that at least breastfeeding has been established, even though the supplementation may have happened.
Yes. Yes, and also maybe on that one, in the hospital, we will probably use the cup and spoon. But when they go home, if they get used to the formula, they'll go for the bottle. Now that complicates issues because of the nipple confusion. The mommy's soft nipple versus the hard one of the bottle, and the babies are very smart. They know this hard one is equals easy flow, and I don't have to work a lot at pulling out that milk, and mommy's soft nipple equals a lot of work and sweating. And so when they get used to that, when you go home, then they will outsmart you, and they'll keep crying whenever they are on your breast, and they'll keep demanding. And so now, because you're desperate to have the baby quiet and full, you'll now fall into their psychology that has worked against you. So I will encourage mothers to breastfeed as soon as possible. As soon as you wake up post-delivery, ask for that baby if you're in the hospital. Encourage that. Even if they won't feed for long, let's supplement for you after you have put them on the breast. Yeah, that's.
Thanks. Thank you, Claire. Shiro, with that mention of nipple confusion, because again, that is something that comes up a lot. When you see mothers, what can you add something more about nipple confusion, and just to enlighten the moms on, in addition to just the texture of the nipple, there's also the flow issue.
Yes, that question comes up a lot. I got a call just before we started. A mom referred to me. She says she's been using the bottle for 4 weeks, and she's been trying to breastfeed, but the baby, every time she puts the baby on the breast, the baby's crying and doesn't want the breast. And it's what Claire has said, there's nipple confusion, and the baby will tend to prefer the bottle over the breast because there's a fast flow, they don't have to work as hard. I encourage moms to try and avoid introducing the bottle before at least 4 months, because one of the reasons, other than hospital who start the formula early, are mom's perception. They believe that they don't have enough milk. And once you allow your mind to accept that, you start to supplement. And then when you supplement, guess what happens? You're decreasing the demand from your breast. So the milk will start to decrease, the supply will go down. And when your supply goes down, you're like, for sure, I do not have enough milk. So you continue adding formula and you're not demanding milk from your breast. So your milk supply will dip. I'd encourage moms, first of all, World Health Organization says, put your baby on the breast within the first hour of birth. Now, unfortunately, if you can't do that, especially if you've had a cesarean section, as Claire has said, immediately you can wake up and have the energy to do skin to skin. Try and latch the baby on the breast, because when you introduce the bottle too early, before breastfeeding is well established, baby prefers the bottle over you. And that's what we're calling nipple confusion, because the flow of milk is really fast. When your breasts are not so full, as the baby suckles, the hormone will stimulate and tell the brain to release hormone oxytocin for milk production to take place. It's not instant, just like the lid or the bottle is. If you tip it over, it will drip, 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 drip. But for your breast, your baby needs a bit of patience. And if you introduce the bottle too early, they lose the patience. And this is not what they're used to. They want it quick and fast. And then you end up having your baby who you feel really rejected, that they don't want you. However, please, there is a way to reverse it. It just takes a lot of patience and a lot of commitment from a mom to decide, okay, fine, now I don't want to supplement, I want to do it breast. Yeah, sometimes you can't do it cold turkey and stop supplementing and go full breast. It can be, you do it gradually, yeah, but it's possible.
Thank you for that. And actually that brings me to the questions on expressing, because you tend to find that sometimes, again, with that demand and supply cycle that we've talked about, that sometimes we advise a mother to express her milk in order to increase supply. Now, Suabi had actually mentioned something about not looking at the milk that you express as an indicator of what you already have as your supply. So I have a question here that I have a 5-month-old baby who has refused to bottle feed. My output while breastfeeding is a lot, but when pumping, it's very little. I go back to work soon and I don't want to wean until after 6 months. What do I do? So Suabi, here is a mom who she's been breastfeeding. She knows she has enough milk because the baby is getting enough on the breast, but she's struggling to get milk out when pumping. So what would be your advice to her?
I would advise her I would ask her when she's pumping, because it would be more effective for her to pump after breastfeeding. That would also stimulate more milk production. Also, how is her fluids intake? How is her food intake? How is her, that will also help when, in terms of pumping. I would also look into what kind of pump she's using, because we want her to be using a pump that mimics the breast as easily as possible. So sometimes it could also be an issue with the type of pump she's using. So the first thing I would ask her to, maybe some pointers. First, pump after breastfeeding. Secondly, what kind of breast pump is she using? We would want to find that out so that we see if maybe there's a fault in it. Because from her question, it sounds like that her milk supply is actually okay. so there's no problem with the milk supply. So it could be just something to do with a few tweaking in terms of the type of pumping and when to pump, and how she's pumping. Is she having enough fluids when she's trying to pump? Is she pumping when she's very stressed or relaxed? So I would advise, I would give those 3 pointers. Pump after breastfeeding, what type of, drink lots of water, lots of fluid, and be relaxed as you're pumping. And just continue pumping, because it's also a demand and supply kind of cycle. So that would be my pointers for her.
Okay, yeah, that's good. Anything to add to that? Any of the other panelists, Shiro, on tips on how to effectively express pump and expression?
All I'd add on is sometimes it might help to massage the breast as you have the pump on, to just help stimulate milk production, because some moms don't really, their breasts are not stimulated as well with just the pumping and without touching your breast. So yes, put the pump on, but as it's going, massage your breast. And as Suabi said, what you express is not an indication of how much milk you have in your breast. Because sometimes moms say, oh, I only express 30 ml. Does that mean that's all my baby's getting? It only means at that point in time, on that day, that's how much you could express, not how much your baby is always getting off your breast. Because that's one of the reasons why I find moms will supplement, because they believe there's very little that comes out in the pump, which means that's all your baby is getting. Also, the best time to pump would be early in the morning. Anywhere between midnight and about 6 in the morning, you tend to have a lot of prolactin, which is the milk producing hormone. So if you can put in a pumping session then, that would be great, or first thing when you wake up in the morning, and definitely pump only 20 to 30 minutes for a pumping session. 20 to 30, no more, because sometimes moms sit there for an hour. 20 to 30 minutes.
That can be very frustrating for moms. Yeah. Datari, I'm sure you get many questions about now when mothers are coming for their visits and now it's time to go back to work, and of course they'll ask you, when should I start pumping, and maybe even from that second week checkup visit. So when do you advise would be the good time to start expressing milk and possibly storing it?
So I'd encourage mothers to start expressing as soon as possible, preferably the first month, if you can, even the first week. So the milk production will depend on how frequently you're breastfeeding your baby and how often you're pumping. You can be able to trick your brain to think that you're actually feeding twins. So you feed your baby and you're pumping for another baby. That way you'll be able to start expressing and storing your milk enough for you by the time you go back to work. Just like the challenge this mother is having at 5 months, she's now trying to increase her milk supply for the baby later on. I'm very encouraged that she's gotten to 5 months. She's been exclusively breastfeeding. She's almost there, and she should just continue and now trick her brain to think that she's feeding an additional baby. So express as soon as possible. If you can do it even the first week, once you're rested, once you get a pattern with your baby, start pumping. After breastfeeding or even during breastfeeding, you can actually get a nice nursing bra that has a place that you can attach your pump, an electric pump, a manual pump. So you're able to actually hold the baby and attach your electric pump and start pumping. So, because we have a lot of milk leakage when we're breastfeeding our babies on one boob, the next boob is still leaking. That's really valuable milk. So pumping as soon as possible. And even when you're going back to work, don't be discouraged by that 30 mils you're pumping. Continue breastfeeding. Remember the baby, your brain thought it's only feeding one baby and it only needs to supply a certain amount of milk. So now you're tricking your brain to say, I need to produce more. So I would encourage her to just continue, and she'll gradually see the milk supply going up. Another trick I tell my mothers to do, as what Sue Abby said, don't look at the milk that you're producing. Cover the milk with a clean sock and then check afterwards, instead of always checking, because it's a bit discouraging. Sometimes you see 20 mils today and you're like, oh no. Cover the milk bottle and just let the milk supply come down. Good.
Okay. Thank you for that. Actually, connected to this is a very interesting question here. My baby tends to want to prefer my left breast over my right, and there's a big physical difference in size. what can I do to make her want my right breast? But also, I always get fuller on the left, so I tend to pump more on that one. She will be 4 months soon, please help. So basically there's an imbalance in supply and breast size. So how can this mother get her baby to drink more from the right? And how can she regulate, recalibrate, rebalance, so to speak? Who would like to take that one? Maybe start with Shiro.
I was going to say the same way babies have a side preference, even moms tend to have a side preference. And I think the fact that babies prefer the left side is where they get to listen, they get to hear the mom's heartbeat. I think it's so sweet that they prefer the left side. However, even for moms, they tend to feel comfortable, especially if you're right-handed, you prefer to hold the baby on the left side. For this mom, I'd encourage her to definitely try to stimulate the right side a bit more, maybe even change the way she holds the baby on the other side, because some babies, yeah, they refuse. But if you change the position and how you're holding, maybe instead of doing the cradle, you can do the football hold on your right side, maybe the baby might prefer and may be enticed to latch onto the breast. Also for her, if it's pumping, definitely the right side is telling you that the demand has been so low that it's decreased the supply. So stimulate it more by having the baby latch on that side, or expressing more on that side, because for sure you will definitely have a change in breast size because of the lack of proper stimulation or a balance from both sides.
Yeah. So Abby, Claire, is there anything you'd want to, maybe Claire, is there anything you'd want to tell that mom in terms of how to calibrate, anything to add?
Now for the milk supply, sorry, I had something to add from the previous question as well. The milk supply,
yes,
as you stimulate, if we could incorporate hot compressions, sometimes that helps to let down the milk and help your body relax, and avoid very cold showers for those who like that, because then the body stiffens. So if we can do hot compressions as you massage the breast, that will let down the milk. Then also avoid distractions. I know we love, in this time of social media, we love putting the baby on the breast, and then you go on your chats and all, or you're watching a favorite TV station. So I would discourage against that. You need a quiet environment. And then for those who go back to work, expression continues. You shouldn't just express at home. And this now would depend also whether you're working with your employer to give you conducive environment and flexible hours. So I'd recommend when you're pregnant, you liaise with your HR or your boss to at least give you that support after the baby comes. For us, we do have a lactation room, and I think many employers are working towards that. That gives the environment to get off the environment where you're working, and no distractions, and there is a set way that you should set that lactation room. And for those who are still intending, there's a guideline by the Ministry of Health, so that should not be an issue. And in terms of teamwork, if you're back to work and you need to be supported, you need to work closely with your team as well, because they need to allow you that time away and not cause trouble. Why are you going away for so long and work is so much? So I find that quite an advantage when there is teamwork. And for employers, if there are any here, let it be that once they come back from maternity leave, at least between 8 to 2 p.m. for the first few months until we get to 6 months. I think it's not too much to ask. Yeah, so for me, that's what I would add. I think Shiro has captured well in terms of the one side preference versus the other. And also one breast apparently tends to be bigger, just like you have 1 foot bigger. Even your breast, one is usually bigger. And I think there is a way you can, but I think for that mother, she wasn't very worried about the size affecting the baby. I think she was like, they prefer one side versus the other. And I think Shiro captured that very well. Yeah, thanks. Okay.
Thank you so much, Claire, about that point of expressing when you go back to work and expressing at the same time as you would feed the baby, and also definitely getting support from your employer, because again, even as we are talking about supporting breastfeeding for a healthier planet through having skilled breastfeeding counselors, it's also very important for to be on board to provide the correct environment, the most conducive environment. Yes, mother's time is protected in the provision in the Health Act, but of course, even if you have the time, you still have to liaise with your line manager, with your employer, so that you can actually use that time wisely, so that you can express at the times that help you protect your milk supply. So thank you very much for bringing that up, Claire. So something else that's come up in the questions is regarding inverted nipples. So this is something we also come across once in a while. So the question is, how do I go about my inverted nipple? I'm 2 months to delivery and one of my nipples is inverted. So she hasn't yet delivered, but she's aware of the inversion and she would like to know how it will affect breastfeeding. Daktari, what I know you tend to see postpartum, but what would be your advice?
Okay, so she's 2 months to delivery. I'd tell her not to try anything just yet. No manipulation should be done before delivery, because if you stimulate the nipple before delivery, you can actually cause premature labor. So we shall deal with it after delivery. So for the mother, we will need to stimulate the nipple before breastfeeding, either by just rubbing the nipple before breastfeeding or using a syringe, which might be a bit uncomfortable, but I think there are different plungers which are a bit more comfortable in the market that she can use to remove the nipple out to help be able to breastfeed. So we do have issues of inverted nipples, flat nipples. So this counseling is given to mothers as they initiate breastfeeding on how to ensure that the baby is not frustrated when they try to latch onto the breast, because this becomes a challenge during breastfeeding, but it's still very possible. I tell her not to be worried now. We will deal with it after delivery.
Thank you. Yeah, thank you for that. Another one to do with the breast is for a new mom who has an oversupply in milk and gets clogged ducts often. What treatment and prevention techniques do you recommend? Sure, I think we've seen a number of these. Would you like to take that one?
Yes, oversupply can be...
And clogged ducts.
And clogged ducts. Okay. One of the things that I'd say for oversupply is maybe to try and do block nursing, where moms nurse frequently as usual, but restrict the baby on one side. And then after 3 or 4 hours of just using that side, then she can switch sides to the other breast. Okay, so that more milk accumulates, and then the body realizes, okay, we are overproducing milk here, and there's not much demand. So the breast that was quite full will have a decrease in demand. For blocked ducts, especially in the beginning, where moms are not emptying their breasts as often as they can, because maybe the baby's stomach is still small and can't take up all that is in your breasts. Block ducts, one of the things you can do is try to massage the breast. Try massaging the breast or put warm compress, massage, and then as you massage that area, you push the blocked duct or whatever, you feel a mass. So whatever mass you're feeling on whatever part of your breast, you massage it and then push it towards the nipple so that then it comes out. Sometimes it can be quite painful, so you might need to take a painkiller or a paracetamol. There's also the issue of engorged breasts where moms feel like they're as hard as an apple. They're rock hard. They know there's milk, but it's not coming out. What do? I'd encourage moms to use cabbage. Cabbage is nice and cool, especially if it's been in the fridge. Once you put on the cabbage, wear your bra, so cover your breast with the cabbage, put on your bra, and it has a nice cooling effect, which will also help to decrease the amount of milk in your breast. And then thereafter, once you feel a lot softer, you can try to express. But for an oversupply, it can be a real headache because sometimes you even get mastitis as a result. So your milk is just coming out too much. We always think that moms are having a low milk supply, but there are actually some moms who are struggling with an oversupply. So my advice for them would probably to do the block nursing. So where you nurse on one side for 3 to 4 hours before you switch sides, as opposed to what we always tell moms, once you finish one side, change and move to the other side.
Yeah, all right. So also connected to supply, because we've spent quite a bit on supply and pumping, and normally what follows next is mother's diet. Always connected to what can I eat to increase my supply, or is there something that, or am I now overproducing because I've been taking too much tea and actually that one usually I have actually several questions about. What should we eat? There's a lady who's asked about uji. Should I eat uji? And then there's another lady who has asked about colic and eczema. And so basically, maybe Suabi, to you, what advice do you usually give for a mother's diet? Because there are actually two questions here. There's with reduced breast milk, and also, what can I do? What can I eat to increase my breast milk? But also, I feel that I'm taking too much tea, and it is causing, I think this must be dill tea, and it is causing me to produce a lot. What can I do? So it's more around mother's diet.
Okay, thanks, Josie. In terms of mother's diet on what to eat, I'd first advise them not to introduce a lot of foreign things that they've never used before, because you don't want them, the mom to start reacting and she's trying to breastfeed. So if you're a mom and you've never eaten jahe, or you don't usually eat jahe, now is not the time to begin eating jahe, because it might produce gas, which may end up actually affecting your baby in one way or another. So my first rule of thumb is just keep it simple. Do what you've been doing. Eat a balanced diet, lots of fluid, lots of hot drinks, avoid cold things, avoid over-processed food, sugary things, food straight from the fridge, drinks straight from the fridge. Secondly, try and not introduce something foreign, something that you're not used to, something that you've never tried before, because it might cause a reaction to you, which might actually also trickle down to the baby. When it comes to was the question regarding overeating, or that was an overfeeding?
It's more or less what you've touched on in terms of they're now drinking too much of the tea, like, and so what are they supposed to do? So I think it's just what you've mentioned about keep your diet simple and don't start eating new things.
Yeah, yes, exactly. So just avoid new things. If you must try something, if you want to try out the dill seeds and fenugreek and all these other things, I'd advise the mom to try them out before the baby comes. So try and take them before. But if your milk supply, you're feeling like it's there's an oversupply, you can actually stop. If it's the dill seeds she's taking, she can actually just stop taking the dill seeds and keep her diet simple and see what works. For some people, bone soup also does a lot, makes them produce a lot of milk. So if you're trying to make your milk, if there's an oversupply, then you can take that off your diet, but just stick to a balanced diet. Snack often, don't eat when you're hungry, just always have something to snack on, so that you're also not stressing your body and stretching yourself. to avoid also overfeeding for anyone who's concerned about overfeeding. Just constant healthy snacks and the main major meals.
Okay, thank you, so Abby. For Daktari, I have quite a number of questions here to do with eczema. My 3-month-old, I have a 3-month-old, I'm breastfeeding. My baby has eczema, and I was told it might be something I'm eating that is reacting to my baby's skin. Then I have another one here that is, tell me about colic and reflux. We've tried to check my diet as much as possible and even added a probiotic to the baby. So baby is 3 weeks for the colic one, 3 months for the eczema one, but again is what am I eating, or what should I be doing differently with my diet? So Daktari, over to you.
Okay, thank you for those questions. So for the 3-month-old baby and eczema, allergies, breastfeeding prevents a lot of allergies, the asthma, the eczema, allergic rhinitis, and that's why we encourage mothers to continue breastfeeding, as mom's proteins in the milk are quite protective and easy to digest. It's very, eczema and breastfeeding is not really linked. We do not when you're breastfeeding, you do not transfer allergens or trigger eczema. So actually that's a myth. So mom can actually continue eating whatever she's normally eating, unless she has personally an allergy to a certain food, which she can now refrain from. When you talk about allergies, people tend to remove a lot of things from their diet and end up getting food that's not, the nutrition value goes down. So you end up eliminating protein. So you don't have a high protein in your diet, and therefore even your milk production, you won't have high protein. So I'd encourage mothers to continue with the kind of foods they're having. Eczema is totally unrelated to breastfeeding. It just prevents it, actually. Yes. And when you're talking about allergies in your baby, I would be more concerned as a health professional and even as a mother, if my baby is not eczema, but more difficulty in breathing, swelling of the mouth, of the face. That's when now we can talk about an allergic reaction. But mom should continue feeding as she's been feeding throughout. And then for colic and reflux. So colic is a mother's worst nightmare, and we try and reassure mothers as much as possible. As scientists already, we do not know what causes colic. So if you do not know what causes something, you can't really say this is what is going to work, and when I give you this, it will alleviate the colic. So all these things that we have, whatever mom is using, the probiotics, the different things that are out in the market, help a bit with some gas that you may think could be the colic, causing the colic, or it helps in small ways, but may not be what is actually helping the colic. It could be something else that's causing what they say is colic. So when we define colic, it's actually crying for 3 hours, for 3 days in a week, for 3 consecutive weeks. So it could actually be something else, and we've called it colic because as a parent, you get anxious, your baby's crying inconsolably for a couple of hours, and you've tried everything from massaging the tummy to an ambient environment, nice soothing music. So all these things are things that we encourage parents to do to alleviate anxiety in the child. But as I said, colic has no cure. It's just reassuring the parents that this time will pass. It does start about 3 weeks and can last up to 3 to 4 months. And it eventually passes. It's just ensuring that the parents have a smooth transition through that period and know that they're not bad parents, they're not doing something wrong. Baby's feeding perfectly fine. Ensuring that the baby is healthy and it's not a medical condition, and it's just passing that time. So it's about just reassuring the parents you can try all these probiotics. Sometimes they help because the baby could actually just be gassy and it's not colic, and that actually releases symptoms. So I just reassure the parents they can continue the probiotics, but this time passes. It's just about letting it pass with time. For reflux, what happens with reflux? You've burped your baby and then there's some milk that comes out afterwards. We try and monitor the weight gain to see if this reflux is actually significant. Reflux occurs in babies because the sphincter between the food pipe and the tummy may be a bit weak. Remember, everything is still pretty small and still trying to work out its way. So you have milk is liquid with gravity. If you put the baby down too quickly, it will come up. And as the sphincter is maturing, it gets tighter and tighter with time. So early on, you have some reflux. And what I advise mothers to do is, even after birthing, keep your baby upright for about 20 to 30 minutes after birthing because of that gravity. And if you have to put the baby down, to keep the baby elevated to a certain angle to avoid the reflux from happening. I'd reassure mothers, if your baby is gaining weight well, there's no need for any medication. It's just behavioral therapy. So birthing the baby and just keeping the baby elevated. If we have good weight gain, we're good. And as baby continues growing, the sphincter gets stronger. And then we'll start our solid foods at 6 months and more will be kept down. So the reflux does resolve. And by 1 year, you have no reflux at all in most babies.
Fantastic, thank you. Very comprehensive. Just one last one here I've seen on allergies, which I thought was also quite interesting. And it was about an adopted toddler who I think the mother wants to breastfeed. So this adopted toddler has never been breastfed before, has multiple food allergies that have been identified, including all animal proteins. Is it therefore safe to breastfeed this toddler if the mother avoids the foods the baby is allergic to? So Dr. what would you, in that case, what would you advise? So this baby is adopted, I'm assuming adopted mother wants to breastfeed the baby. Baby has identified allergies, so should then the mother avoid those foods that the baby is allergic to?
Okay, so in terms of allergy, we say our babies are allergic to many proteins, and sometimes this may not be the case. If you do a skin allergy test, most times you'll also find you're allergic to tomatoes, which you've had all your life, and it's not really an allergy. So it's about how severe is this allergic reaction. As I said, a few rashes here and there, I'm okay with. Continue feeding your baby, and if it's something you're concerned about, you can space the duration. So not every day that they'll have an egg, maybe every 3 or 4 days, so they're able to get their proteins. Because of this allergies and eczema, a lot of children end up being malnourished or lack certain nutrients in their foods because we're so worried about that little eczema or that little rash. And sometimes that could not be the case. So for this mother, she can introduce this different proteins slowly and gradually and just see what kind of reaction is it. Is it a severe reaction to completely eliminate it from the diet? Or is it something that can be given in small quantities so that our baby is still getting the nutrients? And even for her, as she's breastfeeding, she's able to backtrack and see what exactly am I eating that is giving my baby this kind of reaction? Is it significant enough to completely eliminate it from the diet? Or is it a minor reaction that the baby can continue getting the nutrients from these food groups?
Fantastic, thank you, thank you. So I've seen some questions in the Q&A and they're perfectly timed. So one, I have a question on what causes constipation in fully breastfed babies, in a fully breastfed baby who is 7 weeks old, and what can I do to increase my milk supply? So the milk supply one we've talked about extensively, but the constipation one is a very valid question. Shiro?
That's a really common question about constipation. I'm not, sometimes moms believe their baby is constipated when they've gone 1 day or 2 days without having a poo. Yes, in the beginning, it can be quite a lot, but about 3 weeks, I've found that the poo, how regular the poo comes out is changes and it slows down. I don't know what Dr. Wambui would say, but ideally 3 days, 4 days, even 5 with no poop, as long as the baby is exclusively on breast milk, we don't consider them as being constipated. One of the things moms can do to help baby, and if the baby is showing symptoms and signs of being uncomfortable, is trying to massage the tummy, trying to do the bicycle exercises, trying to hold them in a position like they're almost squatting, you know, so pushing their legs in like that, to give them some time to be able to be in that position to see whether they'll be able to poop. But I would not be concerned, and I would not even think of giving my baby water or putting a piece of soap, panga soap, which is what other moms tell each other, to help the baby pass their stool and do a poop. Take your baby to hospital if you're concerned. But again, let me reassure you that if it's been 3, 4, 5 days with no poop, you do not need to be afraid. You do not need to be concerned. And please do not stick up a piece of soap inside the baby's bum. most breastfed babies are not constipated, nor will he or she need any water if they're not yet 6 months.
Okay, that's fantastic. You've actually led me straight into the next question, which was, can I give my baby water after breastfeeding? If yes, what's the guidelines and the quantities? Suabi, do you get this a lot on water while breastfeeding, introduction of water?
Yes, one of the myths and one of the many misadvices that women get is, actually someone even asked me, ulipatia mtoto maji? I'm like, no, earlier on when my baby was just 2 months. And answering this question again is based on the baby's age. Definitely no water and for the first 6 months of life. Breast milk is sufficient enough. It has enough water. Moms will even notice when it's hot, the breast milk looks lighter, meaning the body is also producing what the baby needs at each feed, depending on the temperature, depending on all these other factors. So no water for sure is supposed to be given to a baby. And I know the doctor can even give us the medical part of and the danger of even giving water to a very young baby. I know it has a lot of complications, of which maybe she can just mention it medically, but I would say definitely no water. An exclusively breastfed baby has sufficient nutrients, has sufficient water that they are getting from the breast milk. So that is definitely no water at all for the first 6 months of the exclusively breastfeeding journey.
Yeah, thank you for that. This question I'll ask Claire. So my baby was 3.2 kg, so it's more of a weight question. My baby was 3.2 kgs when she was born. So we went for the 6 weeks injection. She weighed 4.5. This is almost like those mathematics questions. So be ready with a pen and paper. So birth weight is 3.2. 6 weeks is 4.5. But the nurse told me her weight is supposed to be 6 kgs. So does that mean I'm not getting enough milk, or is 4.5 okay? And the reason why I'm throwing this to Claire is because we get this a lot. I've taken my baby for the clinic. The nurse told me, mtoto hapati maziwa ya kutosha kwa sababu hajafikisha X, Y, and Z kgs. So Claire, I'm sending that one to you.
That's a tough one you've thrown my side, eh? No, I think so long as there is a trajectory increase in weight, and so long as the weight falls in there's usually the card that we use that has the 2 lines, and it is in between those 2 lines, then the mother should not have anything to worry about. So I think ideally it should be 600 grams or just slightly less than a kg per month increase. And so that one I'm even thinking is overweight if it is me being asked. But again, like we say, it also depends with how these nurses are cultured and what they've grown up their mother showing them. So sometimes we tend to bring that into our practice. But so long as you're seeing some increase in your weight of the baby, you should not be anxious. They'll catch up with time if they're meant to be bigger. Yeah. So that's the 1.3 within 6 weeks for me is absolutely acceptable. Yeah.
Yes, I agree. If you're working even with just the average, like you've said, 500 to 600 a month in the beginning, then she's actually doing a very good job. It's a mom who's doing a good job.
Yes, very, very good. Because again, the other thing, we don't want to have obese babies, because then we risk them even getting into diabetes and having hypoglycemia. We actually worry when we deliver very big babies, because we even have to observe them in the neonatal ICU for hypoglycemia. And it's usually what keeps the mother in the hospital, just because she got a big baby. So that mother is doing well. That's all I can say for now.
I agree. Thank you, Claire. Thank you very much. Or the other one, we'll just go back to a bit of another point on expressed milk. Can you mix expressed milk? I.e., can I combine milk I expressed 2 hours ago with what I expressed now? Shiro?
Yes, simple answer is yes, you can.
Which also brings me to the one of, I know there were other questions, I don't know how I missed that one, but it was how long can I store my milk? This mom is pumping and storing milk for long, and what to do with the milk if not bottle feeding the baby. I happen to have a lot of milk, so I'm pumping and storing. I think she's just asking for storage guidelines. How long should it stay? I guess in the fridge and in the freezer.
Okay, so in the fridge, the milk can be there for about 3 days. If you haven't used the milk, you might as well just put it straight in the freezer if you don't plan to use it within the 3 days, and it can be in the freezer for 6 months. For 6 months in the freezer from the time you express. But if you're using it daily, then it can stay in the fridge for 3 days. If you pump and leave it on the kitchen counter or in a cool place, 6 to 8 hours, and then you can use it after 6 to 8 hours. Yeah.
Thank you. And just to add to that, just keeping in mind KLPLC and how they like to give us candlelight dinners. So let's just remember also, if you know that they've been an outage for a long time, and especially with frozen milk, if that milk has thawed, as in meaning it's gone from solid to liquid, then you don't refreeze it. You need to take it out of the freezer and you need to use it within 24 hours. So any milk, if there's a power outage and you have milk in the freezer, and even if you have a freezer full of milk, you cannot refreeze that milk if it has moved from the solid form to a liquid form. You have to use it within 24 hours. That's very important because breast milk still has live bacteria. So it's important to also just make note of that. Dr. Ari, I'm so sorry to take you back to another eczema question, but this one is, my baby has eczema, is 8 months, advised not to introduce protein early. What is the doctor's advice?
Okay, so by 8 months, so we've started weaning. Baby has eczema. As I said, most times it's not food related, it's something else. So I'd still advise she can introduce her animal protein to be able to get adequate amounts. If she's not comfortable, she can introduce plant protein. But animal protein is okay. Just introduce it in 1 to 2 week intervals. Give some mincemeat, see how baby reacts with that. Then the next week, try some chicken and see how baby reacts to that. We can delay introduction of eggs, fish until about 1 year of age, and she'll probably see there's no reaction to most of those proteins. So let's get baby on a good balanced diet. Just want to reassure her just to introduce them gradually as she observes for any reaction. Mild skin rash is okay. So she can still continue with her animal and plant protein in her diet.
Okay, thank you. This one is, after how long does the baby reach hind milk? And it's actually related to another question here that was on, could you please explain the fore and hind milk and how it affects baby's poop? Shiro and Suabi, you can tackle that together.
Okay, Suabi, go ahead and then I'll come after you.
So basically hind milk, fore milk.
Hind milk, milk. So once again, I just to reassure moms not to really get this time thing into their minds a lot, because it's actually impossible for us to be able to know, oh, after 10 minutes, now the baby has transitioned from fore milk to hind milk. So first of all, just don't time any breastfeeding event. The breastfeeding process, don't time it, just breastfeed. Indicators of the baby getting a good latch and getting all the milk way down into from the hind milk, fore milk, is the type of stool, as we spoke about earlier. Is the stool mustard yellow? If the stool is mustard yellow, then the baby is feeding well. If the stool is greenish in color, then you know now the baby is not getting deep enough into the hind milk. So you want to try and make the baby nurse for longer so that they can be able to empty the breasts and get the full mixture of all the milk that's supposed to be given to the baby. So how to know is not by timing, it's just looking at the color of the stool. Is it mustard yellow? If it's mustard yellow, fantastic. If it's green, then now you just want to keep the baby longer in the breast so that the baby is able to empty the breast.
Anything to add, Shiro?
Yes, thank you, Sue. I would say that the green poop, it's usually frothy green. It actually looks like the baby has bubbles coming out in the green poop, because sometimes with green poop, some moms, maybe you've had some really green indigenous vegetables that have changed the baby's color. Not necessarily that you're having an imbalance of the foremilk and the hind milk, but if you are having babies having green frothy poop, it's usually an indication of an imbalance, and meaning they're having more foremilk than the hind milk. Again, we would encourage you to empty your one breast completely, and then you can change and offer this other breast. And the reason why you're trying to empty one breast is to be sure that your baby has got both the foremilk and the hind milk. If you're doing 5 minutes here, then you change and give 5 minutes on this side. Most times it's usually just the foremilk, which is about 89% of water. Then again, if you're having the imbalance, the baby will be waking up often and you're wondering, gosh, you fed, why are you not sleeping long enough? Why are you not calm and content? But ideally also it's because they just drank water. So in the same way you have a sip of water, have a glass of water, you may want to feed again in another 30 minutes, the same way for your baby. Why Sue is saying don't focus on the times that, oh, at 10 minutes it will change to hind milk. It's very, very, very difficult to tell. Just focus on finishing one breast. And moms will say, how will I know it's finished? How you know it's finished? Because it's never completely empty. Actually, research says the baby takes in 67% of the milk in the breast. The rest is left in. So you'll always squeeze and find something. They're never completely dry. What you want to feel is lighter. You're like, oh, I feel so much lighter, so much softer than when I started. If that's how you feel, burp the baby and then offer the other side. If you're not too sure, I would stay on the same side and then now try to compress the breast to be sure that you're completely emptying. Compress until now you see when the baby is now starting to fast and say, I want more, then offer the other breast.
Thank you, Shiro, especially for mentioning the compressions. They really do help in order to just make sure that you've emptied the breast and just massage the breast while the baby is there to get all that hind moving. This one is to Daktari. Can I introduce a pacifier at 2 months? Sorry, is it advisable to introduce a pacifier at 2 months?
Okay, I'm sure people have different reasons why they like to introduce the pacifier. No one likes to hear the baby cry, but it's perfectly normal for them to cry. So in terms of the pacifier, the only issue is now that the baby doesn't learn to self-soothe. It's easier when your baby learns to self-soothe, either by sucking on their thumb or their hand. When they use a pacifier, one, in terms of hygiene, it is very hard to keep that little thing clean at all times. It will fall onto the seat, fall onto the baby's beddings, and sometimes the surroundings may not be very clean, and it might risk your baby getting diarrheal diseases, which we're trying to avoid. And then in terms of self-soothing, that means if you give the baby the pacifier and immediately it drops off, you have to keep on going back to put it back in their mouth. They're asleep, you're asleep, it falls off, they can't self-soothe, so you end up having to wake up again and soothe the baby with a pacifier. So it can be quite challenging. But if a mother chooses to use one, it's fine. But just remember what the risks are and also what the inconvenience can be to you also when you're trying to teach your child to self-soothe as well.
Thank you, Dr. Just one more. This is now back to the constipation question. For the constipation part, the poop is like a yellow pebble. Is it constipation? So, Dr. What would you, how in your practice and of course with your experience and your knowledge, what would be constipation for a fully breastfed, exclusively breastfed baby?
Okay, so for an exclusively breastfed baby, mom has not introduced any substitute milk, has not introduced any water. Constipation is hard to pass poop. It's hard poop when you touch it. As you said, a pebble, it can be pellet-like the small goat poops. So it's pellet-like, baby passes it straining, is crying, is uncomfortable, and at some point can even refuse to breastfeed. That is constipation. What we have at 6 weeks, 7 weeks, which tends to happen in a lot of babies, the frequency, those 4 to 12 poops you used to see in a day, reduce, and they can be 3 days, it can be up to a week or 2 weeks, which is perfectly normal. Your baby's breastfeeding well, baby's passing gas well, there's no vomiting, and when they do pass stool, the stool is nice and soft. It's a mustard, seedy, yellow kind of poop. That is perfectly okay. But when you have hard poop, that is now what we call constipation, difficult to pass, and baby's uncomfortable.
Thank you, Dr. This one is for you, Martha. I thought this was very interesting. With the rising cases of the baby switches in hospital, can this affect breastfeeding? I'm directing this to you simply because being a head nurse, and I'm not sure how many cases, maybe nationwide, have been reported of baby switching, but I guess the question is, can this affect breastfeeding? And is this anything that perhaps you have experienced in your career as a nurse? Are we with Claire?
Oh, it's for me. Sorry, I think I missed that one. Now,
It's
baby
for you.
switching. For us, it's been quite a challenge. It really affects the mother's psychological health. And so we have had to place measures that avoid that. And that's where rooming in comes in versus putting the baby in the nursery away from the mother. For me, I encourage that even when your baby is being washed, you're there and you're washing the baby and changing the baby with the nurse, as opposed to just giving some clothes and you're brought for the baby. For the patients, I've had 1 or 2 who have doubted whether that's their real baby. It's really affected. Even when they went home, they would feel that they're not even bonding with this baby just because of that anxiety. And to some extent, we've had to even do DNA at the hospital expense to confirm that actually that's your baby. And then we involve the psychologist just to help this mother come to bonding with the baby. So that baby switch, yes, it's quite something, and all hospitals have got to put systems in place that ensure that does not happen. It should be zero. It should not be tolerated at all. Yeah. So apart from that, I think once psychologically she said, this is my baby, there's absolutely no chance that I was exchanged for a baby, then the milk just flows, because it's almost psychological for the milk to flow. Yeah. Okay.
Thank you for that, Claire. Thank you for those insights, because I know it's something that's not spoken about, but clearly it exists. So, and it is it would have that impact. And then again, just with the question on constipation, because the mother is still here, I think it would be, my advice to you would be definitely please go see a pediatrician, because if you are exclusively breastfeeding your baby and they're still getting constipated, then definitely I would always refer a mother to the pediatrician, because even for us, we work within our scope. And that is why we have to work as a team, because we all have different skill sets and we all have different scopes. So the mom with the baby with constipation, please go see your doctor, and then you'll get the correct advice in terms of dealing with the constipation, softening that stool, But in terms of going forward, if you have established milk supply, just continue breastfeeding as always. I think we are now going to wind down. I'm so happy because we've managed to actually cover questions from last week's session and questions from this week's session. And I think I'm going to recap before I ask you ladies to also share your thoughts. And for me, mine is it's evidenced by the conversation that we've had, that the more skilled breastfeeding counselors and the more expert help that we have for mothers available in a team that is multidisciplinary. And by that, I mean, we have a nurse here, we have a doctor here, we have a certified doula, maternal health, maternal and infant health specialists. By working together, we are able to give informed answers to the mothers. We are able to increase their knowledge, we are able to increase their confidence, and they know that they're not walking this journey alone. And for me, it would be definitely to encourage policymakers to really take this seriously. So for us in Kenya, I would say invest more in training programs for nurses, like what Claire said. Introduce lactation and breastfeeding counseling, not just the technical and biological bit which already exists, but lactation and breastfeeding counseling into the curriculum for nurses, because there is a need for that. For the medical profession, I would say being able to recognize lactation specialists and lactation educators as legitimate people who offer support, so that we can be part of your team. Obstetricians can refer their clients to us for prenatal classes. Pediatricians can refer their clients to us, so that we work together, because we do have that specialized knowledge. And this should be from the grassroots up. ANC clinics, PNC, they should all be able to offer support to a breastfeeding mother, caregiver, talking about giving the correct information when in crisis situations like COVID and HIV, talking about wet nursing, is it possible because we don't have a milk bank, so that introduction of formula should not be the immediate option for a mother who wants to breastfeed but is struggling to do so. And I hope we'll get there. That's my final comment on that. But I really want to hear from you guys as well before we sign off. So Sue Abby, please let me know what your final comments are.
Sorry for the delay. My final comments are, moms, do not feel as though you have a problem when you experience challenges during breastfeeding, especially for second-time moms, third-time moms. There is such a stigma around you being able to know it and to figure it out, even sometimes in some of our medical institutions. So this is just a reassurance that every process, every child is different, whether you've been there before or not. And if you experience challenges, there are actually very many avenues for you to get assistance. You can visit the Kenya Association of Breastfeeding page, ask your questions. There are counselors available to assist virtually. So please do not feel stuck. There is a solution and you can breastfeed. It is a process that we're willing to work with you through, and we're just here to support that process. And you are actually able to, for me, it's just you are able to do it. Just believe that you're able to do it and there is help.
Thank you. Thank you, Suabi. Shiro?
For moms, I'd say seek help early. Seek help early, whereby you're not struggling on your own for too long, where you decide to quit before you've tried. One of the things that may also cause you to get postpartum depression is failure to breastfeed, because you had such a big desire to successfully breastfeed your baby, and then unfortunately you're struggling and you feel, I should know this, so no need to ask for help. Just seek help early, and if it's possible, while you're pregnant, attend a childbirth class or a breastfeeding preparation class that will help prepare you. Because yes, it does come naturally, but not for everyone. So it's always good to learn the theory, learn what you should do before you get to start to practice when your baby is here. I wish you all the very best.
Thank you so much, Shiro. Dr. Wambui?
I'd like to encourage all the mothers out there who are choosing to breastfeed exclusively for 6 months to encourage them to continue to do so. As healthcare workers, we shall hold your hand through this journey from as early as when baby is born. We need to start establishing the breastfeed in the first hour of life. Let the baby latch immediately after you deliver, rather than taking the baby so quickly away from you to examine if it's a stable baby. Let's encourage you to breastfeed from the get-go. Bring your partners in, your support system in when you come for your clinic so we can do a proper follow-up and give you the necessary information you need to breastfeed. For those who are supporting you, how can they support you and how can they hold your hand through this journey when you come to the clinic as well? Do a follow-up call with your doctor, preferably 3 to 5 days after your discharge. Let us know how your breastfeeding journey is so that we can encourage you and we can advise you where we need to before you come for your 2-week review. So as soon as possible, contact with your medical practitioner continuously through this process just to make sure it's successful and you enjoy it as well. All the best, moms.
Thank you so much, Dr. Claire.
Okay, for me, this was a very good session. I'm really encouraged to see quite a number online. I'm not able to see the attendance on Facebook, but I think this is quite something. For me, I'll encourage the mothers to really take care of themselves the prenatal period. Like my colleagues have said, see if you can get some prenatal classes just before you deliver. They're very important. They help to ease off any tension and you have your questions asked. And please involve your partners. The partner role is very, very important. Once you begin early, then it's easy for him to transition with you. And it's also important when you're pregnant the second time, or if this is your first time, visit the institution you intend to deliver in, because then you get to familiarize yourself. Make sure you choose an institution that even has a neonatal ICU, not because we expect each and every baby to go to the ICU, but just in the event that something goes slightly wrong the last minute, those first few minutes are very important for that baby. So that's one thing you need to be careful about. Then once you're there, work with the nurses, cooperate. But if you feel you're still not getting enough, speak out, shout out for those who will come to Avenue. My name is known to everyone and my number is open to everyone. So just reach out. And I wish you all the best. And in this period of COVID, now that in-laws and family support has got to be restricted, the partner or family support needs to be at least one extra person. So if we are able to cooperate with them and they know what to do, that's where now the counselors and the lactational support people come in, then the journey becomes easier for you. So all the best, moms, and it was good having you here. Thanks, Josie.
Thank you so much, Claire. I'm not sure if Martha from ComFeb, who is our partner, would like to say something, but I'm not seeing her online. But again, so thank you to everyone who has been, oh, there's Martha. Yes, Martha, please, a word from you as well. I think Martha is lagging. Might be a connection issue. But I want to, are you with us, Martha? No, there's a lag. Yeah, there's a lag, Martha. I don't know why. But I want to thank ComFeb so much for setting this up again and for allowing us to partner with you a second time. And Thank you too for everyone who joined us on Facebook. And of course, this recording will be available to watch again on Facebook. So I wish everybody a good afternoon, and thank you for marking World Breastfeeding Week 2020
much,
with
Josie.
us. Oh, there
and
you
I'm
are,
sure
Martha.
that most of the quiz we
And Martha has disappeared again. Oh, there she is. Okay, go ahead, Martha. You need to unmute.
Yes, I'm so sorry, my internet is very unstable. So I was saying very much for the panelists who have managed to create time and to answer questions to mothers. And we hold such forums more often because there is need to provide skilled information to new moms. So thank you so much also for the, thank you for being here. We'll share the once it is ready. Thank you so much, Josie.
Thank you. Thank you too, Martha. Thank you, everybody. Bye.
Thanks and bye.
Bye.